So this is actually one of my favorite chapters in Echo is cardiomyopathies. So when we're talking about cardiomyopathies, these are diseases of the myocardium. So it's diseases that are considered primary disorders of the heart muscle itself. So when we're talking the heart muscle, that's the myocardium, the myocardial layer. So that's kind of how it got its name, this cardiomyopathy. So it's diseases of that myocardial layer. And they're not typically related to valvular disease, hypertension, or coronary artery disease. So just think of these three different cardiomyopathies as diseases that affect the myocardium, or disease specifically or primary in the myocardium itself. So the three different cardiomyopathies we're going to discuss. We have dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. So all these cardiomyopathies, they share a whole myriad or a whole bunch of symptoms that can present in varying degrees, such as congestive heart failure, low output states or low EF, fatigue, shortness of breath, edema, swelling, arrhythmias, and even sudden cardiac death. So the cardiomyopathy itself isn't exactly, congestive heart failure, but the cardiomyopathy can lead to a patient being in congestive heart failure. So the first one that we're going to discuss actually is called dilated cardiomyopathy. So the important thing to remember with dilated cardiomyopathy, it has two primary features that are common with any patient that has been diagnosed with dilated cardiomyopathy. So they're going to have, first off, left ventricular dilatation. So you're going to have a very large dilated left ventricle, and then reduced systolic function, or systolic dysfunction. So they're going to have a reduced ejection fraction or low EF. So they're going to have an abnormal low EF and then a very dilated left ventricle. So those are the primary features or primary characteristics of dilated cardiomyopathy. So these patients can also have some secondary features that are common to dilated cardiomyopathy. So some of those are going to be diastolic dysfunction. So we're going to learn a little bit about what exactly diastolic dysfunction is. They'll have chronic elevated left atrial pressures. So they'll have increased left atrial pressures. They'll also have mitral regurg as well as tricuspid regurg. They'll also have secondary pulmonary hypertension as well as right ventricular dysfunction. So when I think of dilated cardiomyopathy, I think of just a big dilated leaking heart. So all four chambers dilated, ventricles dilated, atria dilated. So it's just this big dilated leaking heart. So that as the chambers dilate, remember those annuluses of the tricuspid and mitral valve, they start separating. So then we wind up with, progressing worse and worse mitral regurg and tricuspid regurg. And that just leads to increased dilatation of the atria. All that backs up to the lungs as well. So they have pulmonary hypertension. You're damaging your pulmonary vascular bed. So, I mean, dilated cardiomyopathy, it's a big deal. These patients just get sicker and sicker and sicker. So they typically present with shortness of breath, exercise intolerance. They'll have extremity edema as well. So this is just a little chart showing some of the characteristics for dilated cardiomyopathy. So again, the primary characteristics are going to be our left ventricular dilatation. So we're going to learn a little bit. There's something called the Sphericity Index. So as this ventricle becomes more dilated, it starts to take on more of a spherical shape as opposed to a nice long elongated bullet shape that we're used to seeing. As it dilates, it starts becoming more round, more spherical. We can have apical and lateral displacement of the papillary muscles as it starts to dilate. So that's going to, again, lead to functional mitral regurg. And as it dilates, So we're kind of combining two of those virtual triad conditions when we talk about this left atrial dilatation. So we now have, as it dilates and that reduced EF, the reduced systolic function, we set up a nice environment for stasis of blood, and we run the risk of ventricular thrombus formation. So these patients that have dilated cardiomyopathy, we have large area of blood that's pooled, starting to collect and congeal and potentially form into clots. And they have that reduced ejection fraction. So the myocardium is not pumping that blood, so it's really not circulating. So these patients, again, run the risk of developing ventricular thrombus. They also have left atrial dilatation, so secondary left atrial dilatation. So this could lead to atrial fibrillation, AFib, and also stasis of blood within that left atria. So they also could run the potential of developing left atrial thrombus as well. So all that volume and pressure gets eventually translated back to the pulmonary vascular bed. Yeah, pulmonary hypertension. And it also, like we said, affects the right side of the heart. So the right side of the heart is also becoming large and dilated as well. So they have, functional tricuspid regurg. They'll also have right ventricular dilatation and dysfunction as well. So there'll be systolic dysfunction of the right ventricle as well. So just remember that ventricular dilatation is a requisite. So it's a required component of diagnosing a patient with dilated cardiomyopathy. We can have varying degrees of dilatation. So it can be anywhere from mild to very severe. And we can have varying degrees of systolic dysfunction as well. And this systolic dysfunction occurs even in the presence of non-ischemic cardiomyopathy. So this systolic dysfunction, if you think about it, it's because that heart has become so large, dilated, and stretched out that those myocardial fibers are no longer able to contract properly. So they've kind of lost their tensile strength. They've lost their ability to rebound and snap back over time. As a consequence of this dilatation and systolic dysfunction, this left ventricle, like we said, is going to start to remodel. And again, it takes on more of a spherical shape that further contributes to worsening degrees of systolic dysfunction. So as it becomes more spherical, as it dilates more, that patient's EF is just going to continue to drop. So the major axis, the long axis of the heart, is usually bigger than the minor axis. And this can actually even change with dilated cardiomyopathy, depending on how spherical it becomes. That increasing spherical geometry, we said, will also displace those papillary muscles. And this leads to, again, further increasing mitral regurg and a reduction in the length of those chordae that are attached to that mitral apparatus. Again, so dilated cardiomyopathy is that big dilated leaky heart. So if we draw our ventricles, they're going to be more spherical in appearance. Around. Really kind of exaggerate. So we just think of it as a big dilated leaky heart. So atria are dilated, ventricles are dilated, the chambers are becoming quite round. We have mitral regurg, tricuspid regurg. So we have MR, TR. And we have reduced ejection fraction. So some of the things that we could potentially look for with dilated cardiomyopathy, we can visualize an increased EPSS, so that E-point septal separation between that E-point on our mitral waveform, our mitral inflow pattern, and our intraventricular septum. When we're also imaging our aortic valve, we can also visualize decreased motion or swinging of that aortic root. So that's also indicative of a patient that has reduced ejection fraction. So with end mode. Again, we have increase PSS. You can also see B-bump. Mitral. Again, so that's due to those elevated pressures or elevated end diastolic pressures. We can also visualize with our aortic M mode, so AOB M mode. We can visualize early closure of the aortic valve. So with the aortic early closure of the aortic valve, what it looks like, instead of having that knife sharp drop off as the valve closes, it kind of has a little slope to it, so a little taper to that aortic valve closure. We're gonna have a slide, we'll see that in a minute. With the aortic M mode, we also visualize reduced motion of aortic root. So next time when we're in the lab and actually doing our M mode for the aortic valve, you can actually appreciate how it swings up and down. So these patients with dilated cardiomyopathy, that's one indication of their reduced EF. You lose that swinging or that motion for your aortic root. There you go. So this is here just kind of showing the dilated cardiomyopathy. So this is now our aortic M mode. So here's our root. So we have very little motion up and down. So the swinging of that aortic root. So you can see it's kind of level, kind of flat. And then we get an early closure of the aortic valve. So it's starting to close early rather than a nice sharp cutoff or nice sharp drop, our normal closure pattern. We get this little slope to it. So it's starting to close a little bit earlier as a result of that reduced EF. So once a diagnosis of dilated cardiomyopathy has been made, we have to then quantify the degree of systolic dysfunction, because that's going to help determine prognosis and patient outcome. And we also have to quantify the left ventricular volume. So again, the best method for doing both of those in one shot, killing two birds with one stone, is doing our biplane Simpson's method, where we can utilize our apical 4-chamber and apical 2-chamber views and trace along those myocardial borders. So that allow us to simultaneously, calculate an ejection fraction, as well as getting our ventricular chamber volumes, our ventricular chamber dimensions. Some machines will actually also be able to calculate Sphericity Index off those measurements as well, depending on your software's applications. So assessment of diastolic function. So we can, when we're talking about diastolic dysfunction, this refers to the heart's ability to relax. So during diastole, the heart needs to be able to relax and expand. So there has to be compliance to that heart, and it has to be able to fill during diastole. So patients who have diastolic dysfunction, The heart is unable to relax and fill properly, either due to elevated pressures or due to underlying conditions within that myocardium itself. So we're going to learn a little bit when we get into restrictive cardiomyopathy that this is more of a diastolic dysfunction issue. So with diastolic dysfunction, we can evaluate it with our mitral valve inflow patterns. So we're assessing our E and our A waves when we Doppler our mitral inflow, as well as performing our tissue Doppler on the mitral annulus and measuring the velocities of the mitral annulus. And that would give us something called our E prime velocities. Again, we can also exhibit or visualize a B bump on our mitral inflow. This is associated with elevated left atrial pressures, as well as elevated left end diastolic pressures. So also, when we're talking about secondary findings, the presence of left atrial dilatation and right heart involvement are also essential parts of making a diagnosis for dilated cardiomyopathy. And just remember, there are some other secondary findings we might encounter, like mitral regurg, it's almost a given, the risk of thrombus formation, and secondary pulmonary hypertension. So again, these often occur in varying degrees. And they often depend on the severity and duration of the cardiomyopathy. So when we're talking about left atrial dilatation, if it's present, the severity depends on the duration, how long that patient has had this particular cardiomyopathy. The left atria can dilate quite substantially, so it can get very large. You may even encounter atria that appear larger than the ventricles themselves. This is particularly true when we get into our restrictive cardiomyopathy. So these atria can really, really stretch. Our areas and volumes, again, these we like to measure in our apical 4 and 2 chamber views, the same that we do for our left ventricular volumes. Left atrial measurements of area, dimension, or volume is a marker for long-standing ventricular dysfunction. If the atria become dilated enough, we may be able to visualize spontaneous contrast. So that's that smoke, that swirling of blood that we can see. That's often a precursor to the development of thrombus. Sometimes this can actually even be seen within the ventricle itself in patients that have dilated cardiomyopathy. So again, the spontaneous smoke or spontaneous contrast again is a precursor for thrombus formation. So you just have to be very careful and cognizant if you're scanning and you see a patient that exhibits this spontaneous echo contrast to really assess certain areas of the heart for the presence of thrombus. Particularly utilize, a contrast agent to better visualize, particularly the apex of the ventricle, because we're going to learn these patients, they run a higher risk of developing apical thrombus as a result, and that's usually the nice spot where these clots like to form. So if you kind of think about it logically, the heart's sitting in the chest, apex is down, the patient has a bad heart, so it's not pumping well. So that's kind of where the most dependent portion of that heart. That's where that blood is going to form, it's going to pool, it's going to collect. So these thrombus, they can appear as a laminar, pedunculated, or mobile. So when we get into our cardiac masses, we're going to focus a little bit on the different types of thrombuses and their appearance. So secondary findings. So secondary MR, this occurs again to the remodeling of that ventricle into a more spherical shape. That remodeling displaces those papillary muscles, so the valve leaflets aren't able to coapt properly. And this just leads to ever increasing and worsening mitral regurg. Due to right heart involvement and dilatation or pulmonary hypertension, this tricuspid annulus will also dilate, and this causes our tricuspid regurg. So when we're talking about etiologies of dilated cardiomyopathy, it's not always possible for us to be able to determine an etiology. There's a condition called non-compaction of the myocardium and the LV, and this is actually a form of dilated cardiomyopathy that can be diagnosed with 2D echo. So this non-compaction of the myocardium, it's going to look very unique. You'll have these very deep trabeculations within the left ventricle that you see. And in transverse, it almost takes on like a honeycomb appearance. So you see this very large, deep trabeculations. So during development, the ventricular this is with non-compaction. During development, the ventricular myocardium begins as sinusoids that compact into organized myocardial layers. With non-compaction cardiomyopathy, these sinusoids persist, and they will not allow for the requisite level of contractile efficiency to project LV geometry. Non-compaction can be mistaken for multiple thrombi or the diffuse nature of the sinusoids may make it make the diagnosis possible. Patients that have uncontrolled or poorly controlled hypertension can lead to hypertensive cardiovascular disease. And in the long run, this can also have an appearance of dilated cardiomyopathy. So these patients, again, they'll typically begin with some sort of hypertrophy of that left ventricle. And that'll be followed by moderate dilatation of the left ventricle and global dysfunction. So this is the typical end stage of hypertensive cardiovascular disease. Also, patients that have long-standing renal disease. So these patients are typically on dialysis. And this can result in the characteristics of dilated cardiomyopathy. Patients may also have annular calcifications that can occur with marked hypertrophy. And this is due to metabolic abnormalities and hypertension. So LV systolic dysfunction and poor and congestive heart failure occur due to metabolic effects and long-standing hypertrophy. Sometimes these symptoms can resolve with renal transplantation or more aggressive dialysis regime. So if we're able to get that fluid out, this will reduce some of that dilatation. So this chart just kind of shows some of the prognostic indicators when we're talking about dilated cardiomyopathy. So it's really based on how dilated is that ventricle and how low is that person's ejection fraction. So that's going to be our deterministic characteristics that we're going to look for to determine, a patient's outcomes. So the lower the EF, the worse that patient's outcome is going to be. The more dilated that left ventricle becomes the worse that patient's outcome is going to be. So this just shows some adverse prognosis indicators. So if we have a very large or very high end diastolic volume, so that means, after diastole, we have a lot of blood flow in the heart. And after systole, we still remain with a lot of blood flow in that heart. Once we get over these volumes, that's a bad indication of outcome. When we're looking at ejection fraction, so ejection fraction is less than 40%. A sphericity index, that's going to be less than 1.5. Doppler findings with the most prognostic value is going to be a high E to A ratio. So this is going to indicate advanced stages of diastolic dysfunction. So this is when we do our mitral inflow pattern and we have our E and our A wave. Our E wave is substantially larger than our A wave. We have our this really big. This is our E. Well, we're going to use our pulse wave Doppler. We're going to put our caliper on our at our tips of our mitral leaflets. We'll get our E and our A wave. So in patients that have advanced diastolic dysfunction, they have a very large E and a smaller A. Actually, we'll make this even smaller to look exaggerate. We'll have big E, little a. So that's going to create an E to A ratio. So an E to A ratio greater than 2.5 is a poor prognostic indicator. So that indicates this patient has advanced diastolic dysfunction at this point. And marked elevation of end diastolic and left atrial pressures. Big E, little a. So seen in patients with marked left atrial enlargement so this is seen in patients with marked left atrial enlargement and secondary pulmonary hypertension. So we can also use mitral regurg and tricuspid regurg as prognostic indicators as well. So again, the more severe the MR, the more the LV is dilated, and the more it's going to change the geometry. So increasing amounts of MR and TR provide for worse prognosis. So these patients that are in dilated cardiomyopathy, unfortunately, there really isn't too much that we're able to do for these patients to really ultimately help them. It's more management. But one of the things that we can try and do is biventricular pacing. So remember, these patients, they have systolic dysfunction. Perhaps they're in some sort of arrhythmia. Maybe there's some sort of dyssynchrony as to the way the heart's contracting. So we'll use biventricular pacing devices to try and improve that patient's systolic function in order to try and get some more of that blood out during each cardiac cycle to try and improve some of the patient's symptoms. So patients with dilated cardiomyopathy and a left bundle branch block with mechanical dyssynchrony, they're candidates for biventricular pacing devices. These often prove very beneficial. So clinical studies have shown that successful biventricular pacing can result in improved LVEF, reduction in those left ventricular volumes, and often a reduction in mitral regurg and improvement in symptomatic and functional status. And it does provide a survival benefit. So just remember that with dilated cardiomyopathy, it is the primary indication for cardiac transplant. So ultimately, these patients are going to need a cardiac transplant. This is considered the final step for patients with end-stage cardiovascular disease. So these ventricular assist devices are often used as a bridge to transplantation. So these patients with dilated cardiomyopathy, they essentially are going to need a heart transplant. Cardiologists will use those ventricular devices to kind of bridge that gap between the time, they're able to get a heart, and hopefully they get a heart, and are sometimes used as a destination therapy for patients whom a transplant is not an option. So there is a condition called peripartum cardiomyopathy. So this affects women during the late stages of childbirth through the early portion of through the early postpartum period. So they present with symptoms of ventricular dilatation and systolic dysfunction with secondary MR. These symptoms typically resolve, they typically resolve several weeks after childbirth. The etiology of this really has not been established, though it's thought maybe due to preeclampsia, so elevated pressures during the pregnancy when they become extremely hypertensive and enter hypertensive emergency, or potentially viral in nature. So some of the other cardiomyopathies we're going to talk about also are going to be hypertrophic, and then infiltrative and restrictive cardiomyopathy. So now we're going to transition from dilated cardiomyopathy into what's called hypertrophic cardiomyopathy. So this is kind of an important number for your wall thickness, this 13 millimeters or 1.3 centimeters. So that's going to represent wall thickness when we're talking about our ventricular walls. So that magic number 13, you're going to need to kind of keep that in the back of your mind and remember it. So hypertrophic cardiomyopathy is defined as the presence of localized or generalized left ventricular hypertrophy or thickening of that myocardium in the absence of hypertension and other factors likely to result in pressure overload or an infiltrative state. So these are patients that have developed thickened cardiac muscle, that thickened myocardium, and they don't have, a calcified aortic valve. They don't have aortic stenosis. They don't have systemic hypertension. They don't have a coarctation. They don't have something that's causing that increased afterload. Their muscles, for whatever reason, they just started to develop and become thickened. So hypertrophic cardiomyopathy can be sporadic or can be seen familial. So there might be there's a genetic component to it. Its prevalence is 1 in 500. So in all forms of hypertrophic cardiomyopathy have in common is an inappropriate left ventricular hypertrophy. So we're going to discuss in a moment, there are a couple different kinds of hypertrophic cardiomyopathy. So our classic form of hypertrophic cardiomyopathy, which affects a disproportionate number of constitutes a disproportionate number of hypertrophic cardiomyopathies, is going to be our classic obstructive cardiomyopathy. So I'm just going to throw a couple little acronyms at you, because you might see it in some of the literature described a little differently. That often when you're studying for your boards and reading your book, HOCM. So that's our hypertrophic cardiomyopathy. I'm running out of room. Myopathy. You may also hear the term IHSS. So this is idiopathic hypertrophic subaortic stenosis. Idiopathic. Hypertrophic. Sub-aortic stenosis. We also may hear the term ASH. So that refers to, I'm just going to turn my screen. There we go. ASH. So this refers to asymmetric septal hypertrophy. All right, so when we're talking about our classic form of a hypertrophic cardiomyopathy, so that classic form is going to be our asymmetric septal hypertrophy or obstructive hypertrophic cardiomyopathy. So these will result in a dynamic left ventricular outflow tract obstruction. So that's where that term HISS also comes into play. So idiopathic hypertrophic subaortic stenosis. So what's below the level of the aortic valve? It's going to be our LVOT. So these hypertrophies are typically going to affect that basal portion of the septum. So it typically involves the interventricular septum more than the free wall. And it's going to be typically that basal portion of that septum that's going to hypertrophy. So if we kind of draw our nice aortic valve. All right, so we said that our most common form of hypertrophic cardiomyopathy is going to be this asymmetric septal hypertrophy. So if this is our parasternal long axis view, we have our aorta. So our aorta, aortic valve, LA, mitral. So we're going to have thickening typically of our basal septal wall near that LVOT. So it's asymmetric. It's affecting not the entire interventricular septum, but a smaller segment of it becomes exceedingly thickened comparative to the rest of the ventricular myocardium. So this ASH, or asymmetric septal hypertrophy, occurs in about 70 to 75% of hypertrophic cardiomyopathies. So ASH, when we hear this term ASH, we also have to associate it with, again, our IHSS, so idiopathic hypertrophic subaortic stenosis. So we get a stenotic lesion in our LVOT as a result of that hypertrophy. And we also have to kind of associate ASH with another term. We mentioned it before, that's going to be our SAM. So our systolic anterior motion of that mitral valve leaflet. So this asymmetric septal hypertrophy that's going on here creates an LVOT obstruction. So it creates a dynamic LVOT obstruction. We have narrowing of our left ventricular outflow tract. And those elevated velocities that are now trying to exit out of that aortic valve create almost a suction or a vacuum effect that pulls our anterior mitral valve leaflet up and into that, up into the LVOT. Depending on how hypertrophic that basal portion of the septum is and how strong that suction is, that anterior mitral leaflet can get pulled all the way up into that ventricular septum and actually hit that ventricular septum. So that mitral valve getting pulled up, that systolic anterior motion, leads to a dynamic LVOT obstruction. So we have a particular Doppler pattern that we're able to visualize in patients that have this idiopathic subaortic stenosis. So if this is going on, SAM, if we're getting this suction of that anterior mitral leaflet into that LVOT, this is also going to result in MR. So we're going to have mitral regurg as a result. So we can also have concentric LVH or concentric left ventricular hypertrophy. So that would be thickening, even thickening of all the ventricular walls. So we have concentric. So this occurs about 5% of the time. With concentric LVH, this can be confused with patients that have systemic hypertension issues. So these can be confused with patients that have prolonged systemic hypertension. So just be careful. So concentric LVH. It's also not associated with that LVOT obstruction. Not associated with LVOT obstruction. But what it does result in is a markedly reduced chamber size. So if all the walls are thickened, we have reduced internal chamber dimensions. If you have reduced internal chamber dimensions, we're going to have also reduced cardiac output. So there's less blood flow, leaving the heart. These patients, again, they'll suffer from dyspnea, shortness of breath. They may also become tachycardic because that body is trying to get that extra blood flow out. So we have a lot of blood, returning back to the heart, not so much being pumped out. So the heart's going to try and accommodate by increasing its heart rate. So another example of hypertrophy that we can encounter is apical hypertrophy. That would be hypertrophy, confined primarily to the apex of the heart. So apical is seen in about 5% of patients as well. Apical hypertrophy is more common in the Asian population. We can also potentially see some other hypertrophies that can be isolated, say, to the papillary muscles. Though this is, again, not very common. So again, our technique to use to determine that the septal wall is thickened is to use our ratio to the posterior wall. So we look for a thickness ratio of 3.1 to 1, and that was considered to represent an inappropriate wall thickness and was called asymmetric septal hypertrophy. Excuse me. It should be noted that a number of other disease states can give the same ratios, such as an inferior wall infarct. So just be careful. So if a patient has, again, if we're in our parasternal long axis view, if that posterior wall has become infarcted, if the patient's had a heart attack, that wall is going to become thin. So that thinning of that posterior wall might give you a ratio that's 1.3 to 1, but there may not actually be, septal hypertrophy just because that ratio is 1.3 to 1. So 2D echo is the primary tool used to evaluate known or suspected hypertrophic cardiomyopathy. The presence, scale, and distribution of that hypertrophy can be clearly and accurately determined with our 2D echo. By using 2D along with color and spectral Doppler and M mode, we can fully describe the entire spectrum of hemodynamic abnormalities that are associated with hypertrophic cardiomyopathy. Just remember that, again, concentric forms of hypertrophic cardiomyopathy may not have that obstructive component to it, or that LVOT obstruction component to it. Patients with non-obstructive hypertrophic cardiomyopathy develop symptoms due to pathological stiffness of the left ventricular myocardium and elevated diastolic pressures and small diastolic volumes and reduced stroke volume. So basically what that's saying is that as this heart becomes larger, more hypertrophied, the muscle becomes thickened, it's going to now lose its ability to stretch out. So it's not very flexible anymore. It's not very pliable. It's very strong when it comes to like pumping and ejecting. So these patients may be very hyperdynamic. So the ventricular walls may come all the way down together. So you might have complete obliteration of that chamber during systole. But that heart muscle, it's so thick and so tense that it's not able to relax and contract. And those patients, they're the ones that are suffering now from advanced diastolic dysfunction. So there is diastolic dysfunction that's underlying and associated with this hypertrophic cardiomyopathy, and it's going to present itself in varying degrees. And then it's up to us to determine, how severe is that diastolic dysfunction now. So we said that the vast majority of these hypertrophic cardiomyopathies are going to be asymmetric septal hypertrophy. And the most common place for that asymmetric septal hypertrophy is going to be in that the basal septum. So these patients also have that higher incidences of developing a dynamic LVOT obstruction. So that's what we talked about before, that thickened septum creates a narrowed LVOT or obstructs the LVOT. They also then wind up with that systolic anterior motion of that mitral valve leaflet, anterior mitral valve leaflet, which also adds to narrowing and obstructing that LVOT as well. So on M mode, we can actually visualize that systolic anterior motion of that mitral valve leaflet. So that's one of the characteristics, one of the things that we look for. And then with our aortic Doppler signals, we can also assess the presence of an LVOT obstruction, because that aortic Doppler signal is going to take on what's called a dagger shape appearance. So it's a late peaking systolic waveform. I'm just going to kind of put over here. Obstruction. You can see systolic anterior motion. This is also talking about the aortic valve itself. So the obstruction occurs in mid to late systole, thus diminishing the blood flow. This reduction in flow results in a partial closure of the aortic valve, and there's often a secondary opening as the final ejection of blood occurs. So this is that mid-systolic notching that we could see with mid to late systolic notching of our mitral valve. So we can say there's mid, late closure of the aortic valve. This is that notching there that we can sometimes see. This is aorta M mode. So these notches may be single. You may have several notches. So if you think about it, that obstruction is blocking that blood flow. That reduction in blood flow then it results in partial closure of the aortic valve. And then we get an opening back up of the aortic valve during that final push to get the rest of the blood out. This next slide just shows that example of that M mode. This is an example of a patient that has a dynamic LVOT obstruction. So we can also have use our Doppler to interrogate the left ventricular outflow tract, and we'll be able to document and quantify, the degree and level of this obstruction as well. So dynamic outflow tract obstructions result in turbulence in the outflow tract. So if we put color on, we may exhibit aliasing. With spectral Doppler or pulse wave Doppler, we'll be able to detect elevated velocities. We're going to use our pulse wave Doppler. So we want a Doppler in a specific spot right in that LVOT. So we're going to use our pulse wave gates to interrogate along the LVOT and track the velocities. So we'll kind of sample, start high up in the LVOT. And so we'll be on our apical 5 or apical 3 chamber. We'll start higher up, actually a little bit in the ventricle, and kind of just working our way down through the LVOT towards the aortic valve. Just sampling along the way, documenting velocities. So when these velocities reach the maximal point of obstruction, the velocities will exceed the Nyquist limit. And we'll typically exhibit our aliasing. We can use continuous wave Doppler, which will not alias, to provide a high fidelity analysis of that LVOT. So due to that late peaking velocity that's seen in an LVOT obstruction, these waveforms have a very telltale sign. So this is they take on a very specific Doppler profile. So this is called a dagger shape appearance. So when we're Dopplering our LVOT, so this is going to be our example of what that dagger shape. So this is seen with LVOT dynamic obstruction. So we have flow through the LVOT, it's speeding up, and doesn't reach its maximum velocity until late in the systole. And then we get an abrupt, deceleration, or the valve closes, so we're not getting any more blood flow going through. So it takes on, that dagger shape appearance. So normally, we should have a nice round waveform. So normal waveform would appear more round, with velocities peaking at mid-systole. Just showing that dagger shape appearance to the waveforms. Again, it peaks. Our velocities will peak late in systole, creating that dagger shape. Occasionally, one might encounter a patient that has the anatomy that meets the qualifications of hypertrophic cardiomyopathy, but there's no outflow tract obstruction. In these cases, there's some maneuvers that could be done to try and enhance an obstruction. That's also an important registry study tip. So when a patient does have hypertrophic cardiomyopathy and there is a concern for an LVOT obstruction. So if they have all the, the telltale characteristics, you see asymmetric septal hypertrophy, looks like this person should have a dynamic LVOT obstruction. We can have the patient Valsalva, and this will increase severity of LVOT obstruction. Or we can also use a drug called amyl nitrate. So both of these will reduce pulmonary venous return and will cause an exaggeration. You can say that an increase in severity or an exaggeration of the LVOT obstruction. So also will increase, exaggerate LVOT obstruction. So again, mitral regurg is also going to be a common finding with hypertrophic cardiomyopathy, and this is a result of that systolic anterior motion of that mitral valve leaflet. So that we see with patients that have obstructive obstructive hypertrophic cardiomyopathy. Again, due to that mid to late peaking obstruction and hypertrophic cardiomyopathy, mitral regurg takes on a different contour with a spectral Doppler. So instead of it's late peaking instead of early peaking. So this would be an example of a mitral waveform showing mitral regurg, and you can see you're getting those bright echoes later during diastole. I'm sorry, later during systole. I apologize. So you can see the envelope, but it's not as intense, not as bright. And the real regurg, or the predominant regurg, occurs during mid to late systole. So we said that patients can also have apical hypertrophy. Again, this was more common in the Asian population. This can also be associated with symmetric T-wave inversion on the anterior precordial leads of the EKG. Wall thickness is usually normal in the basal segments of the left ventricle. So where we would typically see hypertrophy, we do not. We'd have nice thin walls. So that's not going to create that LVOT obstruction. Sometimes these hypertrophies are overlooked or not seen. So if a lower frequency transducer is, especially if a lower frequency transducer is used, once you use a higher frequency transducer and shallow focal depth, color Doppler can be used with the low Nyquist limit to fill in the left ventricle. So this will show the left ventricular endocardial borders better. And sometimes we can also utilize, or it's important to remember that we can always utilize contrast agents to better define our endocardial borders. So we also have another variant of hypertrophic cardiomyopathy that involves hypertrophy and obstruction at the mid-cavitary level. So this is called a mid-cavitary obstruction. It may be more difficult to identify because there's no evidence of systolic anterior motion. So basically think about this as like the septum becoming so hypertrophied in the mid segment that when the heart contracts and during systole, it actually comes in contact with the posterior wall and creates an obstruction or narrows. There's a narrowing between the mid segment of that septum and that posterior wall, and it creates an obstruction of blood that was in that apex trying to get out of that heart. So with this, continuous wave Doppler can identify a high velocity jet with a hemodynamic gradient, usually at the papillary muscle level. So contrast agents may be used clearly to define the endocardial borders. You kind of picture that at mid-cavitary obstruction, like if I had my heart, the mid segment, of the septum becomes very hypertrophied, and as it comes in, it creates a narrowing at that mid cavity level and doesn't allow the blood from the apex to pass through to get to that LVOT. Screening for family members. So current recommendations are for first degree relatives to be screened for hypertrophic cardiomyopathy. So if this is something that runs in your family that you know of, it's recommended that you screen for it. Screening should be done annually until the age of 18. Screening should be done every 5 years after the age of 18. Hypertrophic cardiomyopathy can first manifest itself in the 5th and 6th decades of life. This is just a list of some conditions that may mimic hypertrophic cardiomyopathy. So say a patient that has hypertensive heart disease with left ventricular hypertrophy, patients with left ventricular hypertrophy and inferior myocardial infarct, patients with right ventricular hypertrophy, and anomalous papillary muscle bundles, patients who may have cardiac amyloid, left ventricular hypertrophy with anteroseptal ischemia, perhaps a patient has a fixed subvalvular obstruction, perhaps a patient that had spontaneously closed perimembranous ventricular septal defect, patients with low blood volume with left ventricular hypertrophy, conditions that may mimic hypertrophic cardiomyopathy. So again, there are several conditions that may mimic HCM that results in the septal wall being thicker than the posterior wall. So occasionally hypertension or coronary artery disease with an inferior wall infarct can mimic this hypertrophic cardiomyopathy, because we said when there's an MI, that wall thins, becomes scarred and thins. So it could look relationally much thinner than that septum. So to the naked eye or to a sonographer, that may appear as a patient that has asymmetric septal hypertrophy. By noting akinesis of that inferior posterior walls, one should be able to prevent this misdiagnosis of hypertrophic cardiomyopathy. So again, so if that wall has suffered an infarct and becomes thin, there's also not going to be wall motion. So there's not going to be contracting and thickening of that myocardial layer. So you should be able to discern and be able to pick that up. Some adults may have a discrete subaortic membrane. So this can potentially create that subaortic stenosis. This can also lead to hypertrophy of the septum as well. The extent of that membrane will make it difficult with 2D echo to visualize, may make it difficult to actually visualize that membrane. The most valuable clue to this would be the presence of aortic insufficiency. So AI is rarely seen with true hypertrophic cardiomyopathy, but is commonly seen with this subaortic membrane. So we just also have to remember that a prominent muscle bundle or trabeculation in the right ventricle, right ventricular outflow tract, can be mistaken for septum, and that can potentially mimic hypertrophic cardiomyopathy. So it's important when we're measuring that septum not to include those trabeculations in the RV. Other pathologies causing right ventricular hypertrophy, such as pulmonary hypertension, can cause the ratio of the septum and posterior wall to be greater than 3.1 to 1. A membranous septal defect, ventricular septal defect that closes spontaneously may actually protrude into the LVOT. The angulation of the septum may be altered, thus causing an LVOT obstruction. It's another possibility. So hypertension of the elderly, normally seen in elderly, this will increase in septal angulation when combined with hypertrophy due to chronic hypertensive disease. This can also mimic HCM. Patients who have cardiac amyloid or amyloidosis, this can also mimic hypertrophic cardiomyopathy when the distribution of the infiltrate is not uniformly distributed. There's a condition also called athlete's heart. So this can often be mistaken for hypertrophic cardiomyopathy. So in highly trained athletes, they can develop an enlarged left ventricular chamber, as well as a thickened ventricular walls. But the important thing to remember is that this athlete's heart heart usually has a thickness of less than 13 millimeters, whereas with true hypertrophic cardiomyopathy, the thickness will be greater than 1.3 millimeters. Also, with the athlete's heart, there will not be an outflow tract obstruction. Patients that are volume depleted, so they're hypovolumic, they have low blood volumes, may present with a dynamic outflow tract obstruction as well. This is frequently encountered in intensive care units. These patients usually already have a history of hypertension. The low intravascular volume combined with hypercontractility of the left ventricle can potentially cause a dynamic outflow tract obstruction with systolic anterior motion of that leaflet. So another pathology that can mimic hypertrophic cardiomyopathy is ischemia in the left anterior descending coronary artery. This can occur as a result of acute coronary syndrome, or it can be provoked at the time of a debutamine stress test. The distal ischemia results in a more angulated anterior septum. When combined with the hypercontractility state, may result in a dynamic outflow obstruction with SAM visualized. There's a similar lesion that's called a Takabuso. So this is where the apical segments of the heart actually balloon out. Kind of looks like It's terrible. That's kind of like my two-chamber view. My Doppler down here. We'll put a valve down here. So the apical segment of that heart kind of balloons out. So you almost looks like the head of a squid. I had a good picture of that the other night when we were studying. But so this apex will actually balloon out, and you get some narrowing around the mid cavity level. So this can potentially create an obstruction as well. This will actually resolve on its own, and it's also seen in the Asian population. Occasionally, one will encounter a patient with true hypertrophic cardiomyopathy and left ventricular systolic dysfunction. This can represent end stage of hypertrophic cardiomyopathy. Eventually, ventricular function will burn out and the patient will develop global hypokinesis. The dynamic outflow tract obstruction SAM may no longer be present at this point. This diagnosis of end-stage hypertrophic cardiomyopathy may be made when there's been a previous diagnosis of hypertrophic cardiomyopathy. So in order to make this end-stage diagnosis, we have to already have known, that this patient was suffering from hypertrophic cardiomyopathy, and this is just kind of the end stages of that. So again, with hypertrophic cardiomyopathy, these patients typically do not have reduced systolic functions. If anything, they become hyperdynamic. They're increased EFs. So when we're talking about therapy for hypertrophic cardiomyopathy, patients can be given medications like beta blockers or calcium channel blockers. These are aimed at decreasing the contractility of the heart, but these actually only produce a limited benefit. So the goal of this is to decrease that contractility and increase preload and afterload. Increase preload and reduce afterload. We're looking to increase ventricular volumes. So we also want to show another procedure that we can potentially do is something called a myomectomy. So we can actually go in and resect some of that myocardial layer to try and thin it out. This shows substantial success. Or we can also do a procedure called alcohol ablation. So we can ablate segments of that myocardium to reduce. This is good in cases that have patients that have outflow obstruction. So we can ablate just that single portion of that thickened septum and remove that outflow tract obstruction. There's immediate reduction in cardiac mass with surgical myectomy. With alcohol ablation, there's a slower rate in the reduction of cardiac mass. The controlled myocardial infarction occurs in the proximal septum and scarring. Over time, this will reduce the septal thickness. Just be cognizant that these procedures could potentially mess with the the cardiac conduction system. So we also want to be very careful, when we're, performing these procedures, either the alcohol ablation or myectomy, that we're not disturbing any of those nerve conduction bundles that are traveling through the heart. So if you remember, our interventricular septum, carries those right and left bundle branches. We just want to ensure that we're not going to damage the electroconduction system of that heart. So the point of this, or the goal of this, is to essentially shrink the amount of functional myocardium. So the final form of cardiomyopathy that we're going to discuss today is infiltrative and restrictive cardiomyopathy. So they kind of go hand in hand because they'll have similar appearances, and they'll have similar clinical manifestations. So with the restrictive and infiltrative cardiomyopathy, there's a it's relatively an infrequent cause of congestive heart failure. So the primary characteristics of these two, infiltrative and restrictive cardiomyopathy, is that systolic function is preserved. So in these patients, they have normal ejection fractions, they have normal EF, they have normal myocardial contractility, so the ventricles are able to contract normal, but they suffer from diastolic dysfunction. So this is a diastolic form of eventually leads to a diastolic heart failure. There are several disease states that may be restrictive in nature, such as end-stage hypertensive cardiovascular disease, hypertrophic cardiomyopathy, idiopathic restrictive cardiomyopathy, and restrictive heart disease in the elderly. And late stages of dilated and ischemic cardiomyopathy may be associated with restrictive physiology as well. So restrictive cardiomyopathy is the stiffening of the left ventricle myocardium and consequent congestive heart failure due to diastolic dysfunction and elevated filling pressures. So restrictive cardiomyopathy, think of that myocardium now has become stiff, it's non-compliant, it's not able to stretch. So we're going to learn in a second, there's a couple things that can cause that to happen. So remember just that cardiomyopathies, they're diseases of the myocardium. So in this case, this is myocardium that has now become stiff and not allowing for proper relaxation or dilatation during diastole. And that's what leads to this development of diastolic dysfunction. Many times systolic dysfunction will develop later in the course of a patient that is suffering from restrictive cardiomyopathy. This stiffening or this hardening of the ventricular myocardium changes the compliance curve upward to the left, which means that for any ventricular volume, the left ventricular pressure is elevated. So basically, this stiff myocardium in the ventricle is not going to be able to expand, and we still have the same amount of blood trying to get into that ventricle, but it's not able to be compliant and expand. And it's going to drastically increase those left ventricular pressures. This elevated pressure is transmitted backwards into the left atrium and pulmonary veins. And this causes pulmonary venous congestion, pulmonary hypertension. In true constrictive cardiomyopathy, the ventricular dimensions are within normal limits and the atria are dilated. So that's going to be your telltale sign that this patient has restrictive or infiltrative cardiomyopathy. That looks pretty terrible. So they're going to have large dilated ventricles. I'm sorry, large dilated atria. Ventricles are going to be normal in size. They're going to have increased pressure within the ventricles. We'll have stasis of blood, potential development of thrombus. So these ventricles are going to be able to contract normally. But due to the increased pressure, increased ventricular pressure, during diastole, pressure is transmitted back to atria, causing dilatation. So I look for biatrial enlargement with preserved systolic function. The atrial dilatation is commonly associated with our AFib and stasis of blood, and pulmonary hypertension is also common. So we're going to see in a moment. Again, this pressure gets transmitted to the pulmonary veins, so we're going to learn about diastolic dysfunction and what we can potentially see in patients that are suffering from diastolic dysfunction. So restrictive cardiomyopathy, it's a diastolic disease. Hypertrophic cardiomyopathy, those patients, they have preserved systolic function. In fact, they have increased systolic function, so they're hyperdynamic. Their biggest issue is not having enough blood volume within the ventricles. Dilated cardiomyopathy, they have too much blood in the ventricles and a reduced systolic function. So biatrial enlargement, large dilated atria, normal sized ventricles, stasis of blood within the atria. Patients typically have AFib. Again, pulmonary hypertension is common. Again, so with restrictive cardiomyopathy, there's normal sized ventricles or normal sized LV with normal systolic function. There's evidence now of diastolic stiffening. Diastolic dysfunction is accompanied again by this diastolic dysfunction then becomes accompanied by increased wall thickness, and biatrial enlargement is always present. So again, we're going to look for that biatrial enlargement, normal ventricles. So that's one way you can easily tell the difference between dilated cardiomyopathy versus restrictive. Dilated, all four chambers are going to be big and dilated. Restrictive, just the atria are going to be dilated. So the most common cause of restrictive cardiomyopathy is going to be amyloidosis. This is why they use those terms infiltrative and restrictive kind of simultaneously, because amyloidosis is considered an infiltrative disease. So these diseases infiltrate the myocardium. So amyloids get deposited within the myocardium, And that's what leads to this restrictive nature of the myocardium, having it become thickened, and it creates what's called a speckled appearance. Speckled or ground glass appearance. So we're just going to say amyloidosis or cardiac amyloid. Most cause of restrictive cardiomyopathy, CM. Myocardium has a speckled ground glass appearance. It's thickened. So cardiac valves may also be involved in this process of having cardiac amyloids deposited on them as well. So again, this is going to be a diastolic dysfunction disease first. So in the early phases, Doppler inflow patterns may suggest impaired relaxation or an impaired relaxation pattern. As the restrictive pattern progresses, it can be associated with worse and worse prognoses and outcomes. Again, so with restrictive cardiomyopathy, elderly patients with idiopathic restrictive cardiomyopathy, there's mild LVH with no evidence of infiltrate and dilatation of both atria. There may be a secondary pulmonary hypertension or AFib. So that's in patients with idiopathic restrictive cardiomyopathy. So we don't really know the cause of why they developed this restrictive cardiomyopathy. With these patients, we might see mild left ventricular hypertrophy, but we don't see that evidence of those amyloid infiltrates. So complete Doppler evaluation is essential in making this diagnosis of restrictive cardiomyopathy. Early in the course of an infiltrative process, such as an amyloid, mitral inflow shows delayed relaxation. So this chart shows we're going to get into this a little more in detail when we do diastolic dysfunction, but just it's a nice chart to kind of show you your mitral inflow patterns. So this over here on the left is your normal ENA waveforms. So typically we have, bigger E, smaller A. So this just shows, this represents our early rapid filling. That's when most of our blood flow is passing through that mitral valve, entering into the ventricle, then A or atrial kick. In patients that have diastolic dysfunction, where the heart and the ventricles become non-compliant, they're not able to fill properly. In the early stages, we enter a period called abnormal relaxation. So that's the first stages of diastolic dysfunction. So now we have the heart's not able to relax. So it fills, the ventricle fills quite, the ventricle fills quite rapidly with blood, and it's not able to expand to receive the rest of that blood from the atria. So those pressures start to rise in that ventricle quite quickly. So as a result, during that early rapid filling phase, we have much less blood entering, and we rely more on that atrial contraction to squeeze the rest of that blood into the ventricle, to kind of force it in, because we now don't have that pressure gradient because the pressures rose so quickly during diastole. As the disease progresses, we enter a period called pseudonormalization. So in this, we have a similar appearance to what our normal mitral inflow pattern is. But when we do our tissue Doppler, we're able to get our E prime and A prime. And that's when we can unmask, a patient who has a pseudonormalization inflow pattern versus someone who has a normal mitral inflow pattern. So normal, our mitral annular velocity normally, we would have a higher E and a little a. With that pseudonormalization, it appears more like an impaired relaxation or abnormal relaxation waveform. So you can see we don't get any change. And then the final stage of diastolic dysfunction is going to be our restrictive filling pattern. And with this, we have, again, we said we have that very large E and that little a. So we have a very high E to A ratio, and we were talking about that with a dilated cardiomyopathy. So this is indicative of very high pressures within the left atria at this point. So those pressures have now been transferred into that left atria. So we have a very large dilated left atria, very high pressures within the left atria. So once that valve opens up, that mitral valve opens up, we get a very large rush of blood and now entering into the ventricles due to that very high pressure gradient now. So this is patients that have very high pressures within their left atria, within the atria, and then not much blood during that atrial contraction. So this actually shows velocity movements of the annulus. So how much that annulus is moving during diastole. So we can see that there's very reduced movement of that annulus during diastole. So we can also, pick that up with our tissue Doppler. So this just shows, again, that early stages of restrictive cardiomyopathy. So this would be someone in that impaired relaxation or abnormal relaxation phase. So stage 1 diastolic dysfunction, where we have our little e and big A. So again, when we get more into our diastolic dysfunction, we're going to learn about deceleration time as well. So that plays a component too. So again, as that E to A ratio increases, so we have an increase, which is going to be typically greater than 2. That indicates worsening of that diastolic dysfunction and that patient entering into an advanced restrictive filling pattern. So this is an example of a patient who has advanced restrictive cardiomyopathy. So in this, with our mitral inflow, we see a very large E, very high E velocities, a very small A wave. And then when we look at our tissue Doppler, we have a small E and a small A waves as well. So comparatively. So we're also going to get and calculate what's called an E to E prime ratio as well. So that's also information that we're going to hand to the cardiologist when we're doing our echocardiograms. So they're going to compare our E to E prime velocities, and that'll help to determine, the severity of diastolic dysfunction as well. So diastology is actually one of the newer things that a lot of cardiologists are looking for now. It used to be just focused on ejection fraction. What's the F? What's the F? That's all the cardiologists really cared about. It wasn't until really in the last 10, 15 years that they started focusing more on diastology, and now it plays a very large role in echocardiograms and what we do. This whole diastolic dysfunction. It's projected that more and more patients who are actually in heart failure as a result of diastolic dysfunction as opposed to actual systolic dysfunction. So with restrictive cardiomyopathy, it's often a global process and will also occur in the right ventricle as well. So there are some other diseases that are associated with restrictive cardiomyopathy, along with amyloidosis. So some of those are hemochromatosis and glycogen storage disease, as well as sarcoidosis. Again, so some other diseases you want to add to your list are going to be sarcoidosis. Hemochromatosis. Glycogen storage disease. So this chart just kind of gives us a little taste of when we get into a condition called constrictive pericarditis versus restrictive heart disease. So constrictive pericarditis, as the name implies, it's disease of the pericardium, so the pericardial layer of the heart, versus restrictive cardiomyopathy is a disease of the myocardium. So they're going to have similar presentations in the fact that the heart is not able to relax during diastole, but the reasons for that relaxation are very different. So with constrictive pericarditis, the heart is not compliant. It's not able to stretch out during diastole due to a thick, stiffened pericardial layer. With restrictive cardiomyopathy, it's the myocardial layer that becomes stiff. So that difference will have some differences in its presentation, particularly within the Doppler signals that we obtain, and whether or not there's respiratory changes to those Doppler signals. So we're going to learn a little bit more about that when we get into our pericardial disease lecture. But just to kind of highlight that, with the constrictive disease, that's the pericardium. The pericardium appears thick and bright. With our restrictive cardiomyopathy, we have normal appearance of the pericardium. We have dilated atria with our restrictive cardiomyopathy. Constrictive pericarditis typically has normal sized atria. We can have, with our restrictive pericarditis, we have abnormal septal motion. We can see some changes too when we're talking about our mitral inflow. We have respiratory variations that we can see with our inflow velocities. So that's one of the main criteria that we look for when we're concerned about a patient having constrictive pericarditis versus restrictive cardiomyopathy. When they breathe, we'll see increases. So when they inhale, we'll see an increase in that mitral E-flow. We can also potentially see cardiac changes in their outflow as well as in their EKG with respiration. So that's one telltale sign for constrictive pericarditis. But we'll get into that a little bit later in the semester. Again, so here we go. This just kind of summarizes that a little bit. So the two reliable discriminators between constrictive and restrictive physiology are the respiratory variations in that mitral valve inflow, that E wave, as well as our mitral angular velocities. So that's going to be our tissue Doppler. Again, so we look for exaggerated respiratory variation. So we see an increase of greater than 25% in that mitral inflow during expiration. And then with constrictive pericarditis, we have E velocities that are typically more than 20 centimeters per second. Whereas with constrictive pericarditis, we have those reduced E prime velocities. So those little E waves, little E prime waves. So we typically have normal valve motion during diastole when we're talking about constrictive pericarditis. There's a couple other conditions that we can talk about within this chapter. Two of them are endocardial fibroelastosis and hypereosinophilic syndrome. So endocardial fibroelastosis, this occurs in several forms. It can be congenital or tropical acquired or non-tropical acquired. It's associated with hypereosinophilic syndrome. So this results in an inflammation of the endocardium with the creation of a thick endocardial layer. So because this is an inflammatory process, there's usually overlying thrombus. It involves both ventricles and is usually more prominent at the apex. So this is a thickening of that endocardial layer at the level of the apex. So it's like an inflammatory disease process in that endocardial layer at the apex. And because it's this disease process, there's usually thrombus formation that's associated with that, that thickened layer of endocardial tissue. With endocardial fibroelastosis, there's global systolic dysfunction and variable degrees of diastolic dysfunction. In later stages, it has the appearance of dilated cardiomyopathy with the restrictive physiology. And hypereosinophilic syndrome is also associated with the involvement of the posterior mitral leaflet and endocardial fibroelastosis. So that can result in mitral regurg. I'll just kind of recap. Dilated cardiomyopathy, big dilated leaking heart. So we have tricuspid regurg, mitral regurg, big dilated ventricles, big dilated atria, and reduced left ventricular systolic function, so a low EF. So the patient, first and foremost, to make that diagnosis of dilated cardiomyopathy, we need a dilated left ventricle and reduced systolic function, so reduced EF. It's just kind of a snowball effect with patients with dilated cardiomyopathy. So the more the heart's going to dilate, the more regurg you're going to have, the larger the atria you're going to get, the worsening the patient's symptoms. So everything just kind of gets worse and worse and worse. The more it stretches, the lower the EF is going to become. So the more stretched out those myocardial fibers become, the less ejection fraction that patient's going to have. And the less ejection fraction, the more it's going to dilate. So it all just kind of snowballs and snowballs on each other. The ultimate treatment for that is cardiac, they need heart transplant. They could potentially use biventricular pacing or pacemaking devices to try and use that as a bridge towards receiving the heart transplant. So it could work a little bit, maybe if you catch it in the early stages, provide some degree of relief to the symptoms to the patient, and provide some improvement to the overall ejection fractions and volumes within the chambers. But ultimately, those patients typically need a heart transplant. Hypertrophic cardiomyopathy, that's going to be our thickened myocardium. So greater than 1.3 centimeters is considered thickened. We look for septal to posterior wall ratio of 3.1 to 1. The most common form of the most common form of hypertrophic cardiomyopathy is going to be our asymmetric septal hypertrophy. So that's typically involving the basal portion of our interventricular septum. This can lead to a dynamic LVOT obstruction. Associated with that is our systolic anterior motion of that mitral valve leaflet, which also further creates more obstruction of that left ventricular outflow tract. Other forms of LVH or other forms of left hypertrophic cardiomyopathy could be concentric, so all the walls are evenly thickened. This typically does not present with an LVOT obstruction. Those cases also can commonly be mistaken for patients that have hypertensive disease. So remember, with these cardiomyopathies, they can't be someone who has, longstanding systemic hypertension. This is a disease of the myocardium that's not related to or caused by that that hypertensive disease. Can also have apical hypertrophy. That's more common in the Asian population. With hypertrophic cardiomyopathy, we have increased left ventricular compliance because that muscle's become so thickened. We have decreased chamber dimensions. We have increased end diastolic volumes. So again, that pressure can be also passed on to the atria. So those patients, treatments for them include alcohol ablation, myomectomy. So it's actually shaving down that myocardium to try and reduce the volume, reduce the mass of the LV and increase chamber volumes. Just be cognizant that there are some, conditions that can mimic hypertrophic cardiomyopathy, particularly patients that have had a posterior wall infarct. When you're comparing that posterior wall to the septum, Some things that you can see with the hypertrophic cardiomyopathy, if there's an LVOT obstruction, would be that partial closure of the aortic valve, so that notching of the aortic valve due to the LVOT obstruction. You'll also see drawing a blank. You could potentially see the presence of a systolic anterior motion on mitral valve, so SAM. You'll have that dagger shape appearance for your spectral tracing of the LVOT. Restrictive cardiomyopathy will have that biatrial enlargement, so 2 enlarged atria, normal sized ventricle, and that is a diastolic dysfunction disease, primarily a diastolic dysfunction disease. Most common cause of restrictive cardiomyopathy is going to be amyloidosis. So that's, it's considered an infiltrative disease. That's why they also call it infiltrative cardiomyopathy. Other causes are sarcoidosis, hemochromatosis. So again, those patients present with very high atrial pressures. The atria become quite dilated. They're susceptible to AFib, developing atrial thrombus. They will proceed to developing severe diastolic dysfunction. Any questions about anything? Any of these?
Is the quiz this week coming up?
I don't know. Let's go back. Cardiomyopathies. Yeah. So we have a quiz next week on cardiomyopathies. Right? Oh wait, no, it's not. It's we're a week ahead. Are we? Yeah, we're a week ahead. Why don't you guys tell me that? I didn't even look at this. I thought the quiz was this week.
I didn't even know that was wrong until you said that.
Dude, I am on another planet right now. I just want you all to know, like, I had to present to you, to the college, about how well you guys can do pathology research presentations and library research for like the previous cohort. I just gave like a whole presentation this morning on that. And I have to find a clinical coordinator for you guys. Apparently, I'm not allowed to do that. So.
Why not?
I don't know. That's what the accreditation told me. Like the guy called me. He's like, "So who's your cardiac clinical coordinator?" I'm like, "Me." He's like, "Oh, you can't do that." Like, what do you mean? It's like, "You're program director now. You got to do all the admin stuff." I'm like, "Oh God." It's like you got to assign one. I'm like, I don't have anybody. That's all right. That's for another time. Actually told me like, "Hey, we got another week for that." Yeah, we're a week ahead. I'm sorry, we should have done
I'm glad we got it over with. So next
Okay.
week we're gonna cover Next week, we're gonna cover the, what is it? The cardiac disease. Wait.
Yeah, cardiac disease is coronary heart disease,
Yeah.
left ventricular function. Yeah,
All
that's
right.
good. That'll actually probably give us a little time because that's a lot of information. So we can push quiz. Well, I guess we'll keep quiz 3 where it is then. Yeah, so we could do, I think you guys will be fine. This cardiomyopathy stuff is pretty straightforward.
So are we bumping up that quiz, or are we leaving it where it's at, quiz 2?
What do you guys want to do? Bump it up or leave it?
I kind of want to leave it because I want to
I'll leave
look
it.
at it for a little bit.
Sure.
I don't
Sure.
know if you guys do too.
Yeah, we can leave it.
I don't care either way.
All right. Look at that. The student teacher class. Maybe I can. I'll wait till around midterm to assign that. We're basically going to just be teaching each other the transesophageal views. So I'll assign each person like 2 or 3 views, and you'll have to draw it out and like get the information on the view and then present it to the class. We had fun with that last year, and then we were just kind of drawing off each other. So we had a little cheat sheet book of our transesophageal views. So like what level you're at, like whether you're deep gastric, like mid gastric, upper esophageal level, and the angle which you have to rotate the probe. So that's basically what that student teach class is going to be all about. All right, any other questions? All right, so we're leaving this 225. We'll start next week into the cardiac disease states. That's good. That'll give us some time right before break to get ahead. That's good. You guys good with cardiomyopathy?
I'm gonna need to read a little bit more,
Okay,
but I think I'm okay for now.
okay. All right.
Same. I'm with Mary.
All right. Yeah, go through some of the stuff that's on there, like some of the M modes, the tracings, like and just pull up pictures, like what does dilated cardiomyopathy look like? You can just I'll start throwing more pictures on there for you guys, video clips, just so you can see. All right, that's definitely dilated cardiomyopathy. All right, that's definitely hypertrophic cardiomyopathy. That's definitely restrictive cardiomyopathy. I mean, they're telltale, like this what they look like each one. So I mean, you can't mistake one for the other. All right. My computer's telling me it's almost 60 degrees outside and sunny. Maybe go sit out and enjoy some of the rest of the sun. I don't know if any of you have been outside.
I have not, and I have to go to work.
Oh, that stinks. So go. I will see you all next week.
Bye. Bye.
Thanks.
Have a good
bye.
weekend.